Let's differentiate between patellofemoral pain syndrome, patellar tendinopathy, and Hoffa fat pad syndrome. Considering the population, patellofemoral pain syndrome and Hoffa fat pad syndrome are seen more in women than men, whereas patellar tendinopathy is seen more in men. Age group being 10 to 19 to 20 to 40 year in case of patellofemoral pain syndrome. 30 to 40 year is very common for Hoffa fat pad syndrome women, and 18 to 62 year old. Patellar tendinopathy is seen in any age group starting from 15 to 60. The cause could be overuse or overload in each of these syndromes, yet there is a mild tracking of patella evident in patellofemoral pain syndrome. Hoffa fat pad syndrome is more seen in athletic and active people, often with a history of direct trauma or direct blow or a surgery. Whereas patellar tendinopathy, as we all know, tendinopathy load plays a major role. So overload too often can lead to patellar tendinopathy. Location of pain is very different in the three of the cases. Pain directly at the patellofemoral joint, the junction, the C attachment, is profound for patellofemoral pain syndrome. Whereas at the inferior pole of patella, it is the patellar tendinopathy. Whereas inferior or beneath the patella or the inferior fat pad area is considered for Hoffa fat pad syndrome. Swelling is not seen in these people, but it's very profound in these two cases. Tenderness is very much present in each of them, yet in patellar tendinopathy it's not as much as for PFPS or HFPS. Now, what are aggravating factors? The cinema sign, that is, when we sit for a longer period of time, when our knee is into flexion, that causes patellofemoral pain syndrome more profound. Also, post-trauma, this can be aggravated. Now, in terms of patellar tendinopathy, when there is an increased demand on extended knee, or if the person is overweight, when the person goes down the stairs. In Hoffa fat pad syndrome, when there is muscle imbalances, biomechanical abnormalities, elsewhere in the connective chain, the extension of the knee, even post-operative, as I said. What eases the symptoms are basically extension. PFPS patients have a lot of pain in flexion, hence why extension of the knee eases their pain. Whereas Hoffa fat pad syndrome, extension is painful, so flexion eases their pain. How do we manage each of them? Very easy. Patient education in each of them will be there. But for patellofemoral pain syndrome, hip and core muscle exercises, quadriceps strengthening are very important. Also, stretching the tighter muscles are also important to improve the muscle balance and improve the mild tracking of patella. Patellar tendinopathy, squats can be done, leg extension, leg press, especially the heavy slow resistance program that focuses on eccentric to concentric movements. In HFPS, heels can be used. Ultrasound is more evidently found to be helpful. Insoles can be used to raise the heels because it eases the pain. Gait re-education is important. Strengthening and stretching the knee muscles.